And so I'm going to be talking about the role of use of laser ablation in patients with brain metastases. I think that it's important, as with any disease, that when we talk about using a tool, that we take it in the context of the larger disease. And so we should remember that brain metastases occur as part of a larger systemic disease. And while local failure can shorten survival, successful therapy does not improve survival. And so it's really important that the procedures that we choose have minimal complications so that they do not delay the next steps in ongoing care of these patients. It's important to remember that laser ablation is still an invasive surgical procedure, so it comes with anesthetic risks, surgical risks, and procedure-related complications. And so really in this realm, what is our role? So I wanted to touch a little bit on LITT for untreated brain metastases. This is an area of ongoing debate. I think in my mind, the role is still limited. As Dr. Lee said, this is not a decompression tool. And so compared to the standard craniotomy, we don't remove anything with this. As a direct comparison to radiosurgery, which I think is its biggest competitor, I think also our role is limited, mainly because the current technology allows us a limit of heat diffusion to about 2.5 centimeters, which in most cases, other than critical locations, there's no indication for surgery. We can rarely at this time guarantee complete ablation of the lesion. And so most of these lesions are consolidated anyway with radiosurgery. Failed laser cases, as you can see here in these images. So to the left, I use the Monteris system. And so I thought that we had done a nice ablation. You can see to the right, the pre-lit lesion, what looked like the post-lit cavity, which looks like it completely encompasses the lesion. And there's a nice clean eggshell edge around this, suggesting that the lesion was taken care of. But you can see at 3 and 4.5 months that we did not. And so treating the 4.5 months with radiosurgery, in fact, was a lot more complicated than treating before LITT. All right, and so I think this is one of our biggest problems so far. And then there's little data on adjuvant targeted or immunotherapies, and it's in conjunction with LITT, and if there's any synergy there. So I think I can only think of like one scenario in which an untreated brain metastasis would ideally be treated with LITT, and that would be if a biopsy was needed for diagnosis in a single lesion in a low-risk surgical area with planned CNS penetrating systemic therapy to follow. But I think that's highly controversial. What is less controversial is this, which is radiosurgery again and again and again. So technology has gotten so good now that we're using it as first, second, and third line treatment for brain metastases. And so this article by Dan Trifletti and his group show, in fact, how much more radiosurgery we do today than we did back a decade ago. And so as we treat an increasing number of brain metastases with radiosurgery, we are seeing an increasing number of brain metastases regrow after radiosurgery. And so this is not controversial anymore. Obviously, the causes of regrowth are either tumor or radiation necrosis. It still remains difficult to differentiate these two by imaging, and so biopsy is often required, which allows us an introduction into the surgical world. But craniotomy, while effective, still carries not insignificant morbidity. And so this is, when I started, this was the first example. This is kind of one of the reasons why I moved into LITT. So this is a 50-year-old lady, had a single lesion, treated with radiosurgery all the way back on the left. 6 months later, had a nice response. At 18 months, unfortunately, it regrew. There's a question of whether or not we made the diagnosis wrong also, and so did a craniotomy to remove it. What you can see is she had a stroke adjacent to it, left her with, homonymous hemianopsia. In addition, we're also seeing this problem. So this is a 30-year-old lady who had triple positive breast cancer, so a diagnosis that we hope would have long survival. She had 7 of these tiny little lesions all the way to the left, treated with radiosurgery. The lesions were stable but for a while, then started to regrow. And you can see in the middle there that the lesion regrew quite a fair amount. Unfortunately, she saw a local neurosurgeon who said, oh, she's got stage 4 breast cancer and the lesion's deep and difficult to access. And so I don't think any treatment is warranted. So she got additional radiosurgery. And then to the right, you can see the lesion didn't shrink, it regrew actually even more. And actually, interestingly, her PET and spectroscopy both suggested that this was tumor, but when we took this out, it was all radiation necrosis. So it would have been nice, back in October of 2014 to be able to offer her something minimally invasive. And then the last scenario that we're running into today is the use of immunotherapy. So this is a 75-year-old gentleman with metastatic melanoma. He, all the way to the left, he had this lesion treated with radiosurgery. 3 months later, a nice response. He then starts immunotherapy, and 1 month later, he presents with confusion. And you can see the lesion is regrown to its original size. It's got a lot of edema around it. He was 75. Patient and family didn't really want him to undergo a craniotomy. And so he was one of the first people that we offered laser to. And so what you can see here to the left is the prior to LITT images. And then as early as 2 weeks afterwards, you can see that the lesion's not changed in size, but the edema around it has gotten better. And so he was actually he was able to go back onto immunotherapy 3 weeks after its discontinuation. And at 3 months, you can see that the lesion shrunk and followed suit. So I think radiation necrosis being a big indication now for LITT, especially in the setting of immunotherapy. But just to show you that LITT does work with tumor regrowth as well. So 42-year-old lady, this lesion to the left, treated with gamma knife, good response at 3 months, regrowing at 12 months, turned out to be tumor on PET and biopsy. And you can see here that that over the course of 6 months, and this lesion turned out to be stable for a total of 5 years, all she ever needed was LITT. She never actually got any consolidation radiation. And so I think the lesson to learn is that if you can, so in the image second to the left, if you can get your ablation all the way out beyond the lesion, then it gives you your best chance at control. And then this case highlights really where LITT fits into my practice today. So this is a 60-year-old lady with EGFR mutant non-small cell lung cancer. These lesions tend to be multiply metastatic to the brain. And so you can see she got crazy radiosurgery to 23 lesions while she was on Tarceva in lieu of trying to avoid whole brain radiation therapy. She had, and so of all the lesions that were treated, the only one that was problematic was this one in the right basal ganglia, sorry. And what's really interesting is that same phenomenon that we saw with the immunotherapy case, where the lesion itself after laser, 2 weeks after laser, is not significantly different in size, but the edema actually significantly decreases very, very quickly. And by 6 weeks, it's almost completely resolved again. And so this has become, so edema only has become a significant reason for us to laser these lesions. All right, and so a couple of years ago now was the largest study looking prospectively at how we do with LITT for regrowing brain metastases. And so you can see here that while overall survival is pretty good, it's 70 to 80% at about 3 to 6 months. What's particularly notable is that patients with radiation necrosis do very, very well, whereas patients with regrowing tumor obviously less so. This also applies for local control. And so you can see that radiation necrosis control is very good with LITT, tumor control, unfortunately, less so. This may be an index of how completely we ablate the lesion. Because when we broke the data down, what you can see is that there is certainly a difference between the two pathologies. So even with incomplete or subtotal LITT, you can see response with radiation necrosis, but certainly with tumor, if you do not completely ablate the lesion, then there is a high rate of local failure. And so what this is translated to in our own institution is that we use LITT earlier. And so when we first started using LITT, we would wait for these patients to be symptomatic and to fail steroids before we offered LITT. But particularly if your patient is on immunotherapy in our institution and the lesion is regrowing, we don't wait, actually. And so you can see in the top left that lesions of this small size are being lasered These patients go home day one, they only get a single dose of steroids. The pathology is often radiation necrosis, and by 2 weeks after LITT, they are, back onto whatever course they were taking before.